Surprise! We are meeting our old friend Mr. Stephen Grumps again from our previous sketch on PAD workup and diagnosis. If you haven't already seen that one, you might want to check it out. It's pretty great. And also helpful to watch first. This time, however, there's a bit of a different story. He's already been diagnosed with peripheral arterial disease, or PAD, and has also had a CT angiography demonstrating some significant disease in his femoral vessels. His main complaint is bilateral calf pain that increases while walking a set distance, which then requires him to stop at a specific distance due to the pain. After resting, the pain goes away. The pain is diffuse throughout his calf and is aching in quality. However, the pain always returns when he walks the same distance again. He has the same vascular and atherosclerotic risk factors as he did last time. He's got diabetes, high cholesterol, hypertension, smoking, and known history of coronary artery disease with the previous MI. And he required a cabbage for that. Sounds pretty sick, actually, like this old guy here. During the exam, he also mentions that a friend of his recently had to have his foot and ankle amputated because of significant atherosclerosis causing gangrene. He's pretty concerned this is going to happen to him and is looking for some help to prevent this. The STEM question is asking what the most appropriate intervention is for Mr. Grumps. For those of you joining us without having viewed the previous sketch on peripheral arterial disease and its clinical presentation and diagnosis, we recommend that you view that one first. It's pretty freaking great. We've just discussed diagnosis of PAD based on risk factors, a history of claudication perhaps, or signs of chronic limb-threatening ischemia, such as rest pain, ulcers, or gangrene. On top of that, we've performed a few non-invasive tests to diagnose and localize the level of disease, including an ankle brachial index, which was less than or equal to zero point 0.9. What's next? Well, recall that the presence of peripheral artery disease, whether symptomatic or asymptomatic, is a risk factor for other cardiovascular disease. These patients are at greater risk of MI and stroke, and are in need of aggressive risk factor modification. That brings us to our first line of therapy for peripheral artery disease in symptomatic or asymptomatic patients: risk factor reduction and lifestyle modification. That means smoking cessation, exercise, and weight reduction, as well as strict control of diabetes and hypertension. Preventative therapies include antiplatelet therapy and lipid lowering therapy. So we've brought in our recurring symbols for aspirin and statins, the ASA American Sports Association umpire, and a statin steampunk pirate. Hey, wait a minute. Remember our clinical case? Mr. Grumps isn't on an aspirin. And it seems like, while we're at it, we need to make sure that his diabetes and hypertension are under control, and of course, we'll need to recommend that he stop smoking and works on losing some weight, and give him resources to help him with both. Let's keep going with the sketch to see if there's other things we should do for him. Next, we'll focus on symptomatic patients, whom we'll categorize as having either intermittent ischemia or chronic limb-threatening ischemia. We'll start with intermittent ischemia, which can present as claudication or more atypically. Intermittent claudication is defined as reproducible pain or discomfort in a specific lower extremity muscle group that's induced with exercise and relieved with rest. It's classically associated with an ABI measurement of less than zero point 0.9 but greater than zero point 0.4. At Sketchy, we symbolize claudication with dirt clods on a sore leg. The important thing to remember about claudication is that in most patients, it will not progress to critical limb ischemia. That's right. Around 70 to 80% of patients with claudication are likely to become stable or improve. So just calm down. Stop pawing your patient's legs with that weird look on your face, like you just can't wait to poke around in there with a scalpel. I know. You just want to cut something. But let's hold off for a bit. I promise we'll get there. Taking a moment to think back to Mr. Grumps from our clinical case, this means that we can reassure him that most patients with his condition do not go on to need an amputation, and he will most likely stabilize or even improve with lifestyle modification. Patients with claudication should be started on a supervised exercise program, like this guy here supervising the runners with his binoculars. A graded regimen through a rehabilitation program has been shown to increase pain-free walking distance and total walking distance, because this allows the body to develop collateral blood flow, resulting in improvement of symptoms. Studies show that exercise programs are much more effective when the regimen is truly supervised, rather than just performed at home. However, the effects on overall survival are not as clear. After a few months, if claudication symptoms continue and are lifestyle limiting, a trial of cilostazol is usually started while the patient continues his or her exercise program. Cilostazol, also known as Pledol in vascular surgeon jargon, is a phosphodiesterase 3 inhibitor, which inhibits platelet aggregation and promotes vasodilation through smooth muscle cell relaxation. We've represented these effects here with these broken plates and this dilated shirt sleeve hanging out of this lost and found box. Unless they progress to limb threatening ischemia, most patients will stabilize. And therapy should focus on reducing risk factors and optimizing activity levels. Wait. Hold your horses. We are only a few minutes into the sketch. That can't be the answer to the clinical case question already. Well, it turns out that we have already answered it. In patients with claudication, as much as we want to do surgery, the first and most important therapy is lifestyle modification. That question was trying to trick us into operating, but we didn't. Yay, okay, we can move on to the summary now. Wait, huh? We're not done with this topic yet? You want more? Okay, you guys win. Let's say that we got our patient, Mr. Grumps, onto a good exercise regimen that is supervised. We got him on aspirin, cilostazol, and we've made sure his diabetes and hypertension are under good control and helped him stop smoking. But then, 8 months later, he comes back into our office complaining that he's still having the same symptoms, or even that they're getting worse? When should you start thinking, man, this guy might need a revascularization procedure? Generally, after 6 months to a year of medical management, patients with significant lifestyle limiting, i.e., disabling, claudication symptoms may be considered for a revascularization procedure. So we've brought in another dirt clod ridden claudication runner stumbling across the finish line. Notice, too, the scalpels holding up the finish line tape, as well as the word life covered in mud. Looks lifestyle limiting to me. Patients with minimal claudication symptoms, on the other hand, or foot, as it were, are not likely to benefit from further intervention, and surgery might actually do more harm than good. A quick word about aortoiliac disease. These patients have disease of the infrarenal abdominal aorta, iliac arteries, or both. Yep, we're bringing back Lariche. It's pretty obvious this guy wasn't built for mud runs. Recall that Lariche syndrome constitutes the classic presentation of aortoiliac disease. Diminished femoral pulses, erectile dysfunction, see his floppy pant strings, and claudication, typically of the hip, thigh, or buttock. This is termed inflow disease, while anything below the inguinal ligament, in other words, anything infrainguinal, is called outflow disease. These terms will come back into play when we discuss revascularization procedures. Here's the thing about aortoiliac, or inflow disease. If claudication progresses, it can be quite debilitating and affect multiple muscle groups, resulting in difficulty walking. On top of that, aortoiliac lesions like to embolize, which can lead to acute limb threatening ischemia, or the classic blue toe syndrome. Fortunately, excellent long term results have been achieved in these patients after undergoing surgery. So we've moved this guy's finish line closer so that he can undergo surgery sooner. When treating claudication in patients with suspected aortoiliac disease, the threshold to undergo a revascularization procedure is much lower compared to that for infrainguinal disease, and so the procedure usually happens sooner after diagnosis than in patients with more distal disease. The last major indication for revascularization is the presence of critical limb ischemia. This whole time we've been focusing on intermittent claudication. But remember from our last sketch that as disease progresses, transient ischemia turns into chronic ischemia, manifesting as rest pain, ischemic ulcers, or gangrenous changes. Just like this guy resting on the ground but still in pain, with a hole in his sock indicating an ulcer, and the gangrenous other sock. These patients need revascularization as soon as possible to restore blood flow to the ischemic tissue, which can allow ulcers to heal and some gangrenous tissue to be preserved. That means there's no time to dilly dally. Ischemic ulcer on that toe? It's time to go. The presence of ulcer or gangrene may affect the timing of intervention. In general, wet gangrene or abscess needs to be debrided, drained, and packed immediately, before the revascularization procedure, that is. And then the procedure can be performed when safely possible. For patients with dry gangrene and no signs of cellulitis, the limb can be revascularized first, and then the wound can be monitored for healing or need for further debridement. Remember, too, that all patients with evidence of skin ulceration with cellulitis or other limb infection should be started immediately on broad spectrum systemic antibiotics. Unfortunately, by the time chronic limb threatening ischemia sets in, many of these patients will not be candidates for intervention, either because of unfavorable anatomy, significant comorbidities disease, limited mobility, or short lifespan. At this point, aggressive wound management and medical therapy can be pursued, but many of these patients will end up with an amputation within 1 year. We've symbolized a few of the important factors that increase risk for amputation on this amputee here: the muddy heart for comorbid conditions, a black stain for significant gangrene or necrosis, a wheelchair to represent immobility, paresis, and incorrectable flexion contractures, and a stinky pile of socks to symbolize sepsis. I'd stay away from that if I were you. The overall 1 year outlook for a patient with critical limb ischemia is outlined by that sign at the critical aid tent. 50% will be alive with 2 limbs, 25% will require amputation, and 25% dead from cardiovascular disease. All right, so we're done with medical management, and you're considering a revascularization procedure in a good surgical candidate with low procedural risk who's likely to receive long term benefit. The next step? Advanced vascular imaging, of course. We do this in order to evaluate the vascular architecture as well as the site and severity of disease. Remember, obtain vascular imaging only if you're planning intervention. Otherwise, leave those diseased vessels alone. Post mud run meal, anyone? Let the black CT cat with its yin yang collar remind you of CT angiography, which is often the first imaging ordered. The scanner is timed to start when the bolus of IV contrast reaches the aorta, iliacs, and all branch vessels. Drawbacks? Ionizing radiation and IV contrast blasting the kidneys. Diagnostic angiography may be performed to minimize contrast use, but the trade off is that it's an invasive procedure. It's been a few minutes, but remember our clinical case, Mr. Grumps? He's already had this. That's all I wanted to mention about him. We'll come back to him soon. Speaking of those kidneys, oftentimes, patients with peripheral artery disease significant enough to cause symptoms are likely to also have chronic kidney disease. Check the BUN, creatinine, and GFR, as highlighted by the bun bag and creatinine credit card. Definitely know the status of your patient's kidneys, because it may help you decide which imaging modality to pursue. MR angiography is an alternative to CT and can be performed with or without contrast, and there's no ionizing radiation exposure involved. When used without contrast, MRA detects blood flow by comparing moving protons in the blood to static ones in the surrounding tissue. The usual contraindications apply, such as severe claustrophobia, non-compatible pacemaker, etc. Also, gadolinium contrast agents can cause nephrogenic systemic fibrosis in patients with severe renal disease. And lastly, there's good old-fashioned conventional angiography. It's the gold standard for vascular imaging. Contrast medium is injected through a catheter via transbrachial or transfemoral percutaneous approach. Superior resolution and lower doses of contrast are achieved with digital subtraction angiography, or DSA. With this technique, you can subtract the background and are left with an image of the arterial system. Kinda like that drippy ink pattern on this runner's leg. Angiography allows imaging of the vessels in real time, and therefore, interventions can be performed simultaneously. Nice! Unfortunately, compared to other imaging methods, angiography is associated with the highest amount of radiation and with the most severe adverse events, including nephrotoxicity from contrast exposure. Dang. All right, now that we've got our imaging, it's revascularization time. Shall we take a percutaneous approach or surgical approach? The percutaneous approach involves catheter and wire directed balloon angioplasty, stenting, or even atherectomy of the lesion. Atherectomy is where the atherosclerosis is actually removed from the artery percutaneously. How cool is that? Which to pursue depends on the location and extent of the lesion, as well as the condition of the patient. In general, percutaneous intervention is reserved for uncomplicated lesions. These are short, isolated lesions causing stenosis or occlusion. Just like the short, isolated, uncomplicated, worry free kid here holding the catheter balloon. Percutaneous intervention is also an option for poor surgical candidates with more extensive disease. Just like Grandpa here with his heart t shirt that we're using to indicate comorbidities. He may look beat, but don't count him out just yet. In general, endovascular procedures are associated with fewer complications, but higher rates of restenosis. Restenosis is typically managed with a repeat procedure. So, for our clinical case patient, it's probably best to start with a percutaneous approach. Alright, enough with the balloons and child's play. How about open surgery? It's a bit more hardcore and requires more extensive discussion. Our choices here are endarterectomy, where the atherosclerosis is removed by hand, or, I guess, removed by surgical glove? Gotta keep things sterile. Or bypass procedure to redirect flow around the occlusion using autogenous venous or prosthetic graft. Bypass is the most invasive and is usually reserved for stenosis or occlusion of long segments of vessel, multifocal disease, lesions at branch points, or calcified stenosis. Endarterectomy, i.e., cutting the plaque out, may be performed for severe local lesions. Good results have been achieved with endarterectomy for localized occlusive disease in the external iliac and femoral arteries. Hence the big clump of mud getting removed from her iliofemoral shorts. Closing the artery incision involves a patch angioplasty. More distal vessels typically do not benefit from endarterectomy, and this is not commonly seen. So, in our case of Mr. Grumps, our clinical patient, if we have to do open surgery for some reason, this would probably be the right option. And finally, there are surgical bypass procedures, when the stenosed area of the vessel is bypassed by connecting the proximal vessel to a distal vessel with a vein or synthetic graft. We're going to separate these procedures by region. We're either bypassing aortoiliac lesions, aka inflow disease, or infrainguinal lesions, aka outflow disease. Bypass procedures are named anatomically for the artery that the bypass starts from first, followed by the artery that the bypass attaches to. So, if a surgery is called an aortoiliac bypass, that means the graft attaches to the aorta proximal to the lesion and then attaches to the iliac artery distal to the obstruction. To treat inflow disease, there are three basic options. Remember that for bypasses, the goal is to get around the stenosis. Patients with good aortic inflow and lesions in either one or both of their iliacs can undergo procedures that bypass the lesions from the distal aorta to the femoral arteries. If only one iliac artery is involved, a bypass can be placed from the aorta to the iliac artery, called aortoiliac bypass, or from the proximal iliac to the femoral artery, called iliofemoral bypass. If both iliac arteries are involved with disease, you can bypass both iliac arteries with an aortobifemoral bypass. You may also hear femoral-femoral or fem-fem bypass. This is where one femoral artery is connected to the other femoral artery to provide flow that way. There are many combinations of these procedures that you may encounter. The key is to get the blood flowing around the stenosis. Finally, if the aorta itself has too much disease, or patients are not candidates for the procedures we just described, very rarely an axillofemoral bypass can be performed. This is an extensive procedure and connects the axillary artery up at the shoulder to the femoral artery to provide blood flow to the lower extremity that way. See how this girl is pulling that straw all the way up to her shoulder? When considering graft material, there are two main choices: autogenous, which is the patient's own vein, versus synthetic. For inflow disease, the choice is simple: go with synthetic. Research has shown the outcomes are similar, particularly the long term patency rates, and synthetic grafts are easier to use and don't need to be harvested. Just pick the right size and stitch it into place. It's a totally different story for outflow disease below the knee. Once a bypass needs to go below the knee, it's worth it to take the time and care to use autogenous vein as the graft material, which means you have to harvest the patient's own vein from their legs or sometimes even their arms for use. The most commonly used veins are the greater saphenous vein or the internal mammary vein, also known as the internal thoracic vein. In someone who has had a cabbage, their internal mammary vein may not be an option as the whole area may be too socked in with adhesions or surgical scar tissue. Specifically for below the knee disease, autogenous vein is the choice graft material because it has improved long term patency rates and it's also much more resistant to infection. Synthetic grafts should only be used if the use of autogenous vein is not possible for a patient. Now let's discuss the types of outflow bypass procedures. Again, they're named anatomically from the proximal artery to the distal artery. I don't know about you guys, but all these complex surgery names are giving me a headache. Sadly, it's even more complicated this time. When the popliteal artery is involved, usually the name also indicates whether the involved part is above the knee or below the knee. Ugh, my poor brain! Femoral to above or below knee popliteal artery bypasses, and above or below knee popliteal to anterior tibial or posterior tibial artery bypasses are very common. Femoral tibial bypasses are more rare, but are still performed in certain circumstances. If someone has both inflow disease, symbolized by this kiddo on her dad's shoulder, as well as outflow disease, the inflow disease is more important of the two to treat. It can be treated first or at the same time as the outflow. But the outflow should not be treated first, as there won't be any symptom improvement if the inflow is still poor. Whew, okay, we're done with all those funky names. The complications and risks associated with these bypass procedures are related to the steps involved during the operation. During open surgery, clamps are used to control blood flow during the procedure. Clamps are placed both proximal to the area to be worked on as well as distal. The proximal clamps increase afterload on the heart, creating more cardiac work and causing more stress to the heart. Indicated by the runner clamping down on the water tubing, leading to leaking of that heart shaped water reservoir. These can be particularly problematic in patients with multiple cardiac comorbidities. But that's not the only concern when dealing with vascular clamps. Wait, what? There's more? Oh, jeez. After the surgery is performed, either the endarterectomy or the bypass, the clamp needs to be released to allow blood flow to the distal arteries and tissues. And here's where the big problems start. Unclamping causes three different effects. First off, while the clamp is on the vessel, the heart gets used to having it there and adjusts cardiac output as necessary. But when the clamp is released, it suddenly decreases afterload and potentially causes hypotension, which requires increased cardiac output. Oh no! Secondly, unclamping flushes the static and used up blood distally further into the extremities. This blood has become acidotic and hyperkalemic because it was just sitting next to the tissue instead of flowing past it like it normally does. This causes a buildup of lactic acidosis products within the tissues and blood. When the blood starts moving again, it collects all those waste products, and when it reaches the heart, it can affect cardiac function and even cause serious arrhythmias. Third and finally, when unclamped, the restored flow of blood causes fibrin, platelets, and atheroembolic debris that were dislodged during surgery to be thrown down the legs, like these pine needles falling from the tree. They land in the pedal and digital arteries, as well as microvessels throughout the legs, resulting in something called trash foot, which is impaired perfusion resulting in cyanotic toes, severe pain, and livedo reticularis, demonstrated by the pattern on these socks hanging here. This problem can be minimized by thorough irrigation and flushing of the surgical field prior to final vessel closure. Treatment is heparin, debridement if the skin necrosis, and antiplatelet therapy like clopidogrel and aspirin. Patients should be advised to watch for evidence of infection along the graft and at the incision sites, as well as for fevers. Other findings could be fatigue, CT scan with fluid collections, or inflammation around the graft. These symptoms could signify graft infection, which is a very serious complication and usually requires removal of the graft, especially if synthetic graft was used. Infections are more common in the inguinal region, typically related to difficulty keeping the surgical wounds clean and dry. Post-operative care is important in these patients. So we'll finish up with a few brief words about this. Serial duplex ultrasounds to monitor for patency following these procedures are important. So we have our recurring symbol for serial ultrasounds here with these megaphone speakers. Patients should also be placed on antiplatelet therapy post-operatively, especially if they've had open surgery. This is typically either aspirin or clopidogrel or both, depending on the patient and their surgeon. And finally, due to risk of infection of synthetic grafts, prophylactic antibiotics should be given for future procedures that carry a risk of transient bacteremia, such as dental procedures or other surgical procedures. Well, that pretty much finishes off treatment of PAD. Let's quickly summarize. The first line therapy for PAD is medical management and lifestyle modification. This includes starting aspirin, statins, and making sure comorbidities are controlled, getting patients onto a supervised exercise program, and possibly starting cilostazol, a phosphodiesterase 3 inhibitor that may improve claudication symptoms. Revascularization should be considered if there's no improvement after 6 months to 1 year of medical treatment and lifestyle modification. Leriche syndrome, which is characterized by diminished femoral pulses, erectile dysfunction, and claudication of the buttocks or thighs, is another indication for revascularization, as aortoiliac disease benefits from earlier intervention. The last indication for revascularization is the presence of critical limb ischemia, characterized by rest pain, ischemic ulcers, or gangrene. Signs of infection should prompt systemic antibiotics and debridement prior to revascularization. Imaging prior to revascularization should be performed. This should be CT or MR angiography or digital subtraction angiography. Care should be taken to perform imaging only if surgery is to be planned, as all of these imaging modalities use contrast, which has its own complications, particularly in patients with renal disease. Let's finish up discussing surgical interventions. Percutaneous interventions, such as balloon angioplasty, stent placement, and atherectomy, are typically used in patients with short, uncomplicated lesions or in patients that cannot tolerate extensive open surgery. Open surgical options are either endarterectomy, which is best for short lesions in the iliac or femoral arteries, and bypass procedures. Inflow disease, which means disease above the inguinal canal, may be treated with aortoiliac or iliofemoral bypass, aortobifemoral bypass, or most rarely, axillofemoral bypass. These bypasses for inflow disease use synthetic graft material. Outflow disease, meaning infrainguinal disease, typically uses autogenous vein graft whenever possible, particularly when the bypasses go below the knee. Outflow disease may be treated with femoral to popliteal bypass, or popliteal to tibial bypass, or more rarely, femoral to tibial bypass. When there's both inflow and outflow disease, it's important to treat the inflow disease first or at the same time as outflow disease. Intraoperative clamping of blood vessels may result in changes in cardiac afterload and thus affect cardiac output and may precipitate hypotension, a buildup of lactic acidosis and thus arrhythmias, or even trash foot. Postoperatively, patients should be monitored closely for signs of graft infection. Finally, patients should have serial duplex ultrasounds for monitoring of their surgical intervention. Whew. All right, guys, that about does it for peripheral arterial disease. Just be careful to not slip and fall as you guys are heading out of this mud field. You can't imagine how hard it is to get muddy atherosclerosis out of your hair. And frankly, it's embarrassing. All right, I'm out of here. See you next time.